Lung cancer causes the most cancer deaths in the US, and the best way to beat lung cancer is to prevent it by avoiding smoking or quitting if you are a smoker. Catching lung cancer early gives us the greatest possibility of being cured. At Franciscan Missionaries of Our Lady Health System, our experts lead the way in diagnosing and treating lung cancer. Today, we'll hear from Dr. Nick LeBlanc and Dr. Abdulla Majid-Moosa with Our Lady of the Lake. Dr. LeBlanc is a thoracic surgeon and Dr. Moosa is a pulmonologist, and they join us to discuss lung cancer and how incidental lung nodule programs like the one at Our Lady of the Lake are finding cancer that otherwise would go undetected. We discussed how our experts are changing the game in lung cancer detection and treatment and improving outcomes for patients across our region. So let's dive into our conversation. Welcome, Dr. LeBlanc and Dr. Moosa. Thank you for joining us today. It's so great to have you here and to hear from you and all about lung cancer and the lung cancer nodule program at Our Lady of the Lake.
Hey, Lexi. Thanks for having us.
Yeah, thank you for having us. Appreciate it.
We're so glad you're both here today. Can you tell us about your background and the work you do here at the lake? And we can start with you, Dr. Moosa.
Sure. Well, my name's Abdulla Majid-Moosa. I'm originally from Dallas. My wife and I, we moved to Louisiana for fellowship back in 2015. My wife is an oncologist, so we both landed in Baton Rouge at the end of our fellowship being completed. Since then, we've now lived here for 6 years. And over the last 6 years, I've learned a lot, developed a lot, and the focus of my practice has largely become lung cancer and kind of procedural aspects of pulmonary medicine. I have two beautiful twin boys that are 4 years old.
I can serve as testament to Dr. Moosa's statement about his adorable boys, the cute little boys. My name is Nick LeBlanc. I'm originally from Lafayette, Louisiana, just down the road. I went to LSU, New Orleans for med school after completing my undergrad in Greenville, South Carolina at a small university called Furman, where I played soccer and then found my way back here. Did my residency in Virginia at Carilion Virginia Tech in the mountains of Virginia. And during that time period of general surgery, I discovered thoracic. Was a little bit drawn more towards the thoracic and not the cardiac side, and so that led me to the Great White North in Canada that has separated the two fields. And essentially it's a thoracic oncology fellowship for 2 years. And so I was there and then came back down to the lake and been here for a little bit over 4 years now, or right at 4 years. And my work encompasses the oncology, so the cancer perspective, but also a lot of other non-cancerous conditions that I tell people essentially from the neck down, because that's where the esophagus runs and then the lungs. So a big part of our practice is dealing with lung cancer and non-lung cancer as well. I do not have boys or kids, but I got married a little over a year ago, and so is my lovely wife, Mary, and we don't have kids, but we have plenty of animals that are keeping us busy. We're working on our farm. That's what we're doing.
That's funny.
Yeah, it's in process. We need a place to cage all these animals. So we definitely have the animals. We're just looking for one space to hold them.
Oh, that's the challenge, right?
Yeah.
Well, that's wonderful. I'm so glad that you both are practicing here and going to talk to us a little bit about lung cancer specifically. And so we can kind of dive right in. Obviously, I think it's well known that the best way to beat lung cancer is to prevent it, right? But we know that catching lung cancer early gives the greatest possibility of being cured. So are lung cancer screenings recommended at a certain age for everyone who should be screened? Or are there certain things that people should really be looking out for?
There's different lung cancer screening recommendations, but the general guidelines do recommend for really anyone from the age of 50 to 80. If they have a smoking history of at least 20 pack years and they haven't quit smoking, or if they have quit smoking within the last 15 years, it's recommended that they enroll in lung cancer screening and do at least one low-dose lung cancer screen every year. There is also kind of subgroups where people that are at higher risk for lung cancer, like asbestos patients, asbestos exposure patients, and patients that are exposed to radon with a strong family history of lung cancer. Those patients may qualify for more intensive screening, but under the screening trials, it's kind of a blanket statement where smoking is the central focus of identifying patients that are eligible for screening. So like I said, you've got to have at least a 20-pack year history of smoking, which simply means that you have to have smoked on average at least 1 pack a year for at least 20 years. So if you've accumulated at least that much smoking history, which ultimately boils down to 20-pack years over time, and you have quit smoking within the past 15 years, because the thought is that if you've quit smoking for more than 15 years, potentially your risk of lung cancer at that point decreases than in this more selective population. But there are studies that add to the original national lung cancer screening trials all the time. And with these studies, the indications for lung cancer screening are being revised and updated. So to give you an example of that, based on the screening, based on studies that have been performed since the initial screening trials, they've lowered the age from 55 to 50. They've lowered the American Lung Association, for example, has actually gotten rid of the last 15-year smoking requirement. That hasn't quite translated into, the USPTF recommendations, but that's something that's constantly evolving.
Right, and Moosa hit some key points. We used to surveil or screen rather with chest x-rays alone, and that's where that landmark paper came in about 2011 or so, this national lung screening trial, and it found that there was a survival benefit with getting low-dose CT scans. And so, it's based on a pack year, which basically means if you're a pack a day for a year, that's 1 pack year. If you smoke 2 packs a day, then you only need 10 years of smoking that much to where you're a 20-pack year patient. And so that if they're that number or higher, then they certainly fall into that category. And then, like Dr. Moosa said, with quitting, 15 years within that window, they still meet that. Some people have gone say, like, look, you're always at increased risk, even though it drops down to baseline as the longer you're out from smoking, they still want to catch it early if possible.
Yeah, definitely. It's good to know that there is a range, right, depending on how much you smoked or even kind of given it up and stayed away from it. It helps improve your outcomes or possibilities there. I'm curious if, I know there's many people that assume that only smokers are susceptible to lung cancer. And is that the case? Are there other lifestyle factors or genetic factors? I think you talked a little bit about this, Dr. Moosa, that could put people at risk for lung cancer or lung disease outside of smoking?
Actually, I want to go back to adding one more point about the National Lung Cancer Screening Trials. So the whole point of designing screening is identifying patients that are most at risk for lung cancer, right? So the criteria with which we currently screen patients is primarily formulated from that National Lung Cancer Screening Trial patient population. And the whole intent of designing that trial was to find patients that will almost certainly benefit from lung cancer screening. Because when you design a trial like that, you want to find the patients that you're most likely to find a benefit from, and you can show that benefit. You don't want to design a trial and then the benefit was so subtle that you can't believe it. And I don't know if that makes sense, Lexi. But so the patients that they picked, the premise of picking those patients was that almost certainly those patients are the highest risk for lung cancer. That doesn't encompass all the patients that are at risk for lung cancer, right? So like I was saying before, people with history of asbestos exposure, people with a family history of lung cancer, people, now we've identified radon exposure as being a risk factor for lung cancer. There are other risk factors for lung cancer as well that are important to acknowledge. But at this time, there hasn't been enough formidable literature to standardize those risk factors as saying, okay, if everyone's got so much asbestos exposure, they've got to be screened. So that's a decision that's kind of made in congruence with your providers, basically your healthcare providers. And secondly, when insurance companies are creating kind of standards for, we'll pay for screening for this person, we won't pay for this person, it's hard to standardize some of that data. So unfortunately, the screening trials don't include everyone that is at risk for lung cancer screening, but what it does captures the people that are most at risk for lung cancer in over time. Right. So that was the first thing. The second thing is, around the country, there is an increase in the incidence of lung cancer among non-smokers. Right. And so that is one of the advantages of the lung cancer program that we have at our institution, which is that we also have a robust incidental lung nodule program. So what an incidental lung nodule program is that anybody that walks into the lake system and gets a scan, and let's just say their scan identifies a lung nodule or a spot that could be concerning for cancer, we have a software that kind of overreads those radiology reports and catches those scans. And then we review those scans, and through this program, we've identified just as many lung cancers as we have through our screening program. And this program is just as effective at catching cancer earlier than in advanced stages as our screening program, almost as good as our screening program has been. So what do you think, Dr. LeBlanc?
To answer the question about whether someone has to smoke, that's not accurate. Lifestyles that may put them at increased risk is secondhand smoke. So if you work in a casino and they allow smoking, or a bar, you get exposure to that. The problem, as Dr. Moosa was saying, we don't know how to quantify that. Okay, you worked for 5 years in the bar, but what does that mean for direct smoke? So those would facilitate a discussion with a primary care provider or your pulmonologist or whoever you're seeing on a regular basis, and then you may meet indications for a CT scan, a screening CT scan that does not necessarily meet these criteria that we mentioned earlier. Because you're right, like radiation can cause cancer. So a lady has breast cancer, had radiation. We know 15, 20 years down the road, that can cause a lung cancer in that area of radiation. The radon exposure, asbestos exposure, things like that. So, and environmental. So, in China, they have an increased risk for lung cancer just because of the pollution that they have in some of their communities. So, it certainly is not just these things that we mentioned, but again, those would be something for you to discuss with your primary care provider. And specifically some mutations that we're seeing more and more evidence is coming out with these specific genetic mutations, and this EGFR is one of the more common ones that we've been studying. And these are typically ladies that can develop lung cancer who have never smoked a day in their life, and they tend to be younger females who have never smoked. And in the data, it shows it's typically of Asian descent. So we can't screen all of those patients, but if there is a familial line or the family history of it, then it's certainly worth pursuing that discussion about whether you should get screened or not.
Yeah, absolutely. That's so interesting. And I think it really makes sense that it's really not a one-to-one translation for those who smoke and those who may be exposed to other lifestyle or even genetic factors. I'm curious, and I think that's also why it's so important that you continue to follow up with your primary care provider and communicate if anything's changing with your health. What are some of those? Are there any symptoms, let's say, that you would have or feel that you should notice or look out for that to share with a primary care provider specific to lung care?
Early stage lung cancer is most commonly without any symptoms. And that's so easy to comprehend because early stage lung cancer usually comes on in the form of like a spot in your lung, right? And your lungs are, the surface area of your lungs, for example, when you put them out, it's like greater than the surface area of a tennis court, right? It's a huge amount of surface, and you've got a lung nodule there. That's unlikely to cause any symptoms to a person just from the lung nodule itself, unless it's close to an airway and it's irritating you and it causes a cough. So central cancers can cause a cough. They can also bleed, because cancer cells stimulate angiogenesis, which is growth of blood vessels, and that can cause that cancer to bleed, and so people will cough up some blood periodically. Sometimes if the cancers are invading the chest wall or the pleura, they can cause some chest pain. Those are, if the mass is big and it's displacing a significant amount of your lung, it can cause shortness of breath. But those are symptoms that we see most commonly in advanced lung cancer, where the cancer has grown big enough to actually make an impact on that giant surface area of your lungs and actually cause symptoms, or is in an area where it directly impacts or irritates your lungs. So unfortunately, symptom-based evaluation for lung cancer usually results in advanced lung cancer identification or later stage identification of lung cancer. Even if it's not advanced like stage 4, you're usually finding it in the latter stages.
Most are going to be asymptomatic, so having no symptoms whatsoever, no sequelae, no recognition of it. And that's why, alluding to what Dr. Moosa talked about earlier with the incidental discovery, that's where we want to find them. We want to find them when they're small, just starting to change or grow, and then we find them before they cause symptoms, because if we wait for symptoms, which can be quite dramatic, they can present with a cough, coughing up blood, or hemoptysis. If it's growing into nearby nerves or arteries or veins, things like that, they can cause congestion of the veins or bleeding with the arterial supply. Or if it's up top, like up high in the chest, it can cause issues in the arm and the eyes and things like that. Well, we don't want to wait for that. We'd rather catch it earlier. So I think the biggest thing that I tell patients, because we see this commonly, I've had this cough for 2 months and they just gave me antibiotics or whatever. That's normal. I think what patients need to be aware of is it's things not getting better. So if something is persistent, like you have a cough, okay, it could be a virus, it could be a bacterial pneumonia, but if you're treated appropriately, antibiotics, time, and things don't get better, well, could that cause of the pneumonia be an underlying cancer that has blocked up the airways and created this pneumonia? And that's where, okay, you treat it, you got an x-ray, here's the pneumonia, here's some antibiotics. What's not getting better? Okay, that's what then usually leads to a CT scan, and that's where we've discovered what's actually going on. So it's the common things being common, but they're not improving. So that persistent thing and something's not quite right, that warrants a further investigation.
I think that's a really important point. And I actually want to add one more thing, is oftentimes we discover cancer when there's unexplained weight loss in patients. And kind of like Dr. LeBlanc was saying, something that's just persistently bad. It's just not, you don't have the ebbs and flows of like a typical viral or an infectious condition. That's a really good point that he brought up. Yeah.
Yeah, it's difficult to get into the weeds of all the manifestations that can happen.
Right,
because in late stage, obviously someone could have seizures or nervous changes. Well, that's because it's spread to the brain.
Right.
They could have liver problems where it's spread to the brain, or bone pain, it's spread to the bone.
Bones,
and
yeah.
Some cancers can even cause like syndromes where the body's secreting tumor hormones from this cancer, but that's obviously a rare thing. But then when you take the cancer out, that syndrome gets better. So there's a lot to cover over what symptoms could be there, but it's the key things. It's recurrent. It keeps coming back. It persists. Or losing weight. I mean, losing weight is typically always a concerning finding when we hear about
unexplained.
Weight loss.
Yeah, unexplained.
Yeah, unexplained weight loss.
Right. Yeah.
Well, we'd love to talk more about the Incidental Lung Nodule program. It's really fascinating how this program enables us to catch cancer that might have otherwise gone unnoticed. And digging into that process and how the program works a little more, You alluded to this earlier, Dr. Moosa, that you are taking a scan of a patient who may have had the scan done related to another reason. And then when that scan comes to the team's then looking for possible cancer on the scan. Am I describing that process correctly?
Yeah, you're right. So essentially any scan that's been ordered through the emergency room or through a primary care provider, if that scan shows a finding on it that is concerning for lung cancer, we have a software system that reads through these radiology reports and then identifies these scans. Once these scans are identified, they're brought to a lung nodule coordinator. We actually have a full team. There's a ton of people that work behind the scenes to get this kind of running smoothly, but eventually these screens are reviewed by that team. And some of those scans are then reviewed by myself, Dr. LeBlanc, or Dr. Cassidy, and then we establish the most concerning scans that are presented at our weekly lung nodule conference. So at that weekly lung nodule conference, that's a multidisciplinary conference that's attended by thoracic surgery, such as Dr. LeBlanc, Dr. Cassidy, myself, other pulmonologists, interventional radiologists, hematologists and oncologists and radiation oncologists, and really any other subspecialty that wants to come. So we discuss these scans, and kind of in a collective, after a collective discussion, we conclude on the best next step for that patient. And then those recommendations are then taken back to the patient and their providers, their team of providers, to kind of facilitate the next steps in that person's care. Like I said, we've been fairly successful identifying lung cancer early, even through that program, although it's an incidental program, but we still have been fortunate to identify lung cancer early. And it's a program that, as a team, we're very proud of. And I'm sure Dr. LeBlanc can kind of speak more to that too.
Yeah, it's a phenomenal program that we have in this system that catches these incidental. So incidental, as it implies, is something that was not expected but was discovered. And so you may go in for right lower quadrant pain and they think appendicitis. Well, in those abdominal CT scans, we catch the lower cuts of the chest and the upper part of the abdomen. And there have been countless nodules that we have seen and say, okay, what is that? Let's figure out what that is. So then the patient will get a CT of the chest, and then we go from there as to, okay, this looks concerning. We need to biopsy it. You know, people aren't expecting that. Like, wait, I just had appendicitis and they just took out my appendix. What do you tell me now? I might have lung cancer? Well, we don't know, but it is something there that warrants follow-up. So, again, we don't want to know that because we want to hear I just had appendicitis, but we do want to know it because if it is a lung cancer, well, now we're treating it at a stage 1 and potentially curing that patient of it. So, with the meeting with everyone from all the physician providers to the nurse navigators to all of the coordinators of this program, they are at this weekly conference helping get what the patient needs and getting them, educated in smoking cessation, so helping them stop smoking, all this other guidance and counseling that we provide. So it's truly a phenomenal program that we have here.
It really is. Like you said, many patients fear when they're going in to check for one thing and then the doctor comes back and says, you have something else. And that's really scary. And when you're able to catch it so much earlier, it's not as hard to treat. And it's really cool that we have an entire team of different doctors and specialists who are looking at the scan just to make sure everything is okay. And that's really amazing that you can have so many experts focused on one patient and just really invested in how we can create the best outcomes for our patients in the community.
Yeah, it's certainly cool. And the patients truly, we appreciate as physician providers because, of course, we all think that we know the best course, but there are times where we don't know the best course. And it's nice to have colleagues that you can bounce ideas off of and say, here's what I'm thinking. What do you think? Like, well, have you considered this? Actually, no, I didn't consider that. So, okay, we'll delay the scan a little bit more, or we'll move the scan up. And then it also is reassuring to the patient that, like, whoa, you mean to tell me a team of physicians looked at my scan? Like, Yeah. We were all there. Basically, you had multiple consultations in one presentation, and so I think that helps set their mind at ease as well. So that what we're telling them isn't just, well, I think you need this cut out. Well, of course you do. You're the surgeon. You want to cut everything. Well, not necessarily, but here's what the team recommended, and this is what I think we should do, and then offer that advice to them.
Absolutely. And that's such a great advantage of being a patient with us, and also would save them, I would think, a lot of time and speed up treatment if needed.
Yeah, I concur with that. And I think the ultimate benefiter is the patient. We're all improving as providers as well through this process, because I'm constantly getting perspectives from Dr. LeBlanc per se. Separate from this, there's never a talc fluoridesis that I would do at bedside without talking to Dr. LeBlanc or Dr. Cassidy first now. And that's not something I necessarily always did before. But these are perspectives you get by talking to each other. And so I think similarly with lung cancer care, we're constantly trying to improve our standards. We're bringing, I'll give you another example. There was a landmark trial approved called a Checkmate trial that was presented in the New England Journal of Medicine. And it suggested a new treatment protocol where chemotherapy and immunotherapy were administered first, followed by surgery. That trial was published sometime in, I want to say, May of last year in the New England Journal of Medicine. I would say within a month, we had got that protocol down, and all the eligible patients that we could find through our program were going through that. That's an incredible speed of adoption. And that was because one of our providers brought that trial to our lung MDC, and we discussed it, and that improved all of our knowledges and collective knowledge, and ultimately led to an improvement in patient care.
That's so fascinating. Based on how often this team meets for this conference, I'm wondering, have you been able to track and show how many lung cancers you've been able to detect through this program?
Yes. So every quarter, we review, our lung cancer registry tracks all the lung cancers diagnosed at the lake, what their stage is, what their treatment course is. And so every quarter we track the number of patients that have been identified through our lung cancer screening program, through our incidental lung cancer program, incidental lung nodule program, and separate from both of those programs, just at the lake in general. And these are metrics we track. We try to compare ourselves to national cancer registry data. For example, one of the things we do track is time from diagnosis to treatment, and our intention is to get the patient as soon as possible from diagnosis to treatment. We are constantly looking at ourselves in comparison to other cancer programs around the country, and we want to improve our times and our treatments to where it is really the best care that can be provided just anywhere in the world.
Yeah, and I was going to mention that earlier with the benefit of the multidisciplinary team approach and with all the providers there. It's not infrequent where we have someone discuss as an incidental finding to diagnosis, to staging, to treatment with surgery, radiation, or what have you, all within a few weeks. Because all the providers are aware at that time and get them in, and all the tests are ordered at once, basically the PET scan, the imaging scans to make sure the patient doesn't have disease outside of the lung or something like that. And once that's back, they are there then available to go for their treatment. And it's typically quite fast. That's always our goal.
I wanted to add to what Dr. LeBlanc said. One of the things that I think adds to an advantage that we have is that I'm actually housed in the same office as Dr. LeBlanc. We're actually sitting 4 doors from each other right now. And what that allows is that from the time that, let's just say, a lung nodule is presented to us, and the decision is made to biopsy that lung nodule and find out if it's cancer. And let's just say I do the biopsy. So I do the biopsy, I stage the patient in the same procedure, at least in their chest, and then I order the scans that need to be ordered to fully stage that patient. And then I pass that patient on to Dr. LeBlanc and Dr. Cassidy. And so that process is very seamless. We have the same office staff, so they're tracking the scans. And as soon as the scan's done, the appointment's made. As soon as the breathing tests are done, the appointment's made. And so that process, because I think we share the same office staff, we're in the same office, also works fairly seamlessly to where I think it improves our diagnosis to treatment time.
And I think another thing that we see from our side is, which we all can relate to, if you get told that you have a cancer, you want it treated yesterday. Yep. And that's something that we have to reassure patients that, like, yes, it's going to take a week or two, but I promise you, your prognosis, your staging should not change in that interval that we are taking, because we don't want to cut corners, right? We want to make sure that they're appropriate. The two requirements that I have for surgery for most of my patients would be, one, that they want surgery, they are okay with the risk and benefits and alternatives of surgery, and also that they can safely tolerate surgery, because our goal is to give them that long-term survival benefit, especially using the Checkmate trial that Dr. Moosa was talking about, where we give upfront chemotherapy and immuno-targeted therapy and then surgery. Well, there is a survival benefit to that, and so we want to give that to them, but I don't want to harm them with surgery. And so those are my two requirements. So if they meet that, say, look, we are planning for surgery. A lot of times we actually get them on the book, and I tell them it's easier to take you off the schedule than to squeeze you in. So we secure that date about a week or two later, and then we get the rest of their scans, get their cardiology evaluation, get their lung tests, whatever they need. And then if something comes up, well, then we can always push the surgery back a week or something like that. And I think that's the big thing we have to address with patients, that, look, we have some time to not cut corners. You know, you are still getting done in a timely fashion, and we will get you through this.
That's incredible, because it's reassuring, I'm sure, to your patients to know that you have some of the best, brightest minds on this, and they're taking the time to really make sure the path we take is the right one and what's going to be best for them.
I hope so.
Yeah. We're trying.
I think they do. I think they do.
Yeah.
Yes, definitely. Yeah. Well, I'm going to switch gears a little bit here. And I think it's on the same kind of vein as talking about the collaboration and really the team environment at the lake. And you and your team are providing world-class care right here, close to home in Baton Rouge, which is so important for our community. And Our Lady of the Lake has the most advanced robotic program in the state, with, of course, highly skilled surgeons and the largest fleet of robots in Louisiana. Can you talk to us a little bit about the robotic surgeries that are performed to remove cancers and how this technology that we have here impacts patient outcomes, particularly, talking about time and getting people back to their lives and recovered, particularly regarding recovery and the time and scarring?
Yeah, from the surgical perspective, it's quite fascinating. The standard has been what we call a thoracotomy, or an open, bigger incision. And then we dwindle that down to what's called VATS, or video assisted. And the robot platform still fits under that category where it is video assisted, meaning we're using a special camera to do that, but the incisions got even smaller. And with a VATS, the surgeon is at the bedside with an assistant, and then you use what I describe as long chopsticks to kind of move their rigid instruments that you control at the end of them, and then you're doing it. So it's technically more challenging than the robot, where the robotic platform, small incision, we, the surgeon at the bedside, we dock everything, we get all the ports in, and we set it up. Then we go to a console adjacent to the patient, and we are then controlling the arms from the platform. But we are still doing the operation. Many patients think that, the robot's doing this. Like, no, we're not there yet. Maybe one day we'll be replaced, but we still perform the operation. But the difference is we have an additional fourth arm. We have the camera as an arm. We have an assistant arm, so I can retract the lung, or retract the esophagus, whatever we need to move, and then lock it in place, and then work with our other two arms. And those instruments have 360-degree articulation. So it's like your hand is inside the patient. And that's what I mean by it's easier than the VATS. In fact, a lot of the surgeons, at the time, middle of their career to latter career, surgeons were like, well, I don't want to learn this VATS. I'm doing it open. And that's okay. That's what you want. You want your surgeon being comfortable with the operation they do. But we know that it is a longer recovery, a little bit more time off of work and things like that. And then you had them adopt the robot because it is easier than the VATS. And our standard now is patients, most all of our patients after a lobectomy, so removing an entire lobe, are home potentially the same day. If not, they stay overnight with us and they go home within 24 hours. So they have surgery by noon-ish. They're usually home, or even in the afternoon. They're home usually by noon of the next day. We leave one tube in, and that typically comes out in the morning after surgery.
Which is incredible.
Yeah,
that is.
It truly is, and you don't have to worry about all these extra pain blockades that we have to worry about with the open incision. And to be mindful, if we need to do an open incision, we need to do an open incision, whatever we need to do to be safe. But that is exceedingly rare with the robotic technology and what we do here. And we have helped set up the pathway. We have national guidelines and looking at data, and we've implemented that into our platform and our program where they get all the education before, so they have the expectation. And obviously, what you're told and what you experience are two different things, but I do believe that when they hear, look, the two guarantees of surgery that I tell patients, pain and scar. And both of those are a spectrum, and most of them are on that mild side of the spectrum. So scarring, very minimal, pain, very minimal. In fact, we try to use little to no narcotics whatsoever because we know it suppresses or decreases their breathing rate. It slows that down. It slows the gut down. It slows their mental awareness down. So we do not want that. We want patients the day of surgery up and out of bed, walking around, doing what they would do at home, except have a chest tube on their side for a few hours. And then that comes out, and most patients are back to their normal life within a few days, if not they really will have some soreness, some reminder of surgery. As I tell them, you're going to be reminded that you had surgery, but that's okay. That will get better with each day. And most people are back to work as soon as they want to go back. If they want a week off, 2 weeks off, that's fine with me. Some of them call us chomping at the bit a week. Can I go back to work? It's like, okay, what do you do? Okay, you're not submerging yourself in water and you're not trying to lift a car. Yes, you can go back to work.
Do you find it's getting easier maybe to get patients comfortable with the idea of robotic surgery, where before they might have been scared of it at first, and once you explain how it improves their recovery and reduces pain afterward, they're a little more open to the benefits of it?
Yeah, I can confidently say I've never had a patient say, well, I don't want that. I want the open incision, or I want the VATS incision. No, they are more than comfortable with the robot platform, especially when they understand that it is not doing the operation. Because there are some people, I want to make sure that you are, yes, that is, we are the ones controlling the robot. It's a fancy, expensive way to hold the instruments for us and lets us do the operation safely.
Yeah, and it's good for them to know you're in the room with them too.
For those patients who ask that, that's what they want to know, that we're going to be there. It's like, oh yeah, we are in the room, we are at the bedside until everything is safely in place, and then we step aside, but we are still in the room the entire time.
But I will say one thing, which is that no conversation about robotic technology would be incomplete, especially in the lung cancer space, without mentioning our robotic bronchoscopy program. Which is something that was, let's just say, came to kind of the market around 2019. The Lake launched our program late 2021, early 2022, and we've really, really taken off. What the robotic bronchoscopy technology allows you to do is to biopsy nodules with a high degree of accuracy, with a high degree of safety to the patient too. And our program's really taken off. In fact, we just celebrated a few weeks ago having completed 1,000 robotic bronchoscopes, which is phenomenal and speaks volumes for the work that our staff has been doing behind the closed doors to grow the program. We are just one of the first few cancer centers around the country. Although we came to the market a lot later than these other places, we raced and we're one of the first few centers around the country to have met this milestone. So I think it's something that our team can be very proud of, and kind of adds to our robotic portfolio.
Yeah, absolutely. Congrats to the team. It's incredible and really just shows the experience that our team has with using this type of technology to help benefit our patients.
And what Moosa's leaving out, or you mentioned briefly, but the high degree of accuracy, the gold standard would be anywhere so the past way that we would do this is it would be a biopsy from outside in, so a CT guided. So they would use a CT scan to help guide their needle into the lesion. And you look at numbers that are anywhere from 90 to 95% accurate with that. Our numbers, they sent it to us today, about 97% accurate for getting our answers. And it's even higher when the lesion is 2 centimeters or more. And so it's a nice thing to be able to tell patients that we have used this so much and we feel comfortable doing it. Even these smaller nodules that might be less than a centimeter but are concerning, that, we say, look, we're going to give it the best chance that we can. And by the numbers, it is the best chance that we can give them. And if we don't get the answer, well, then we talk about what else we can do. And the technology is truly fascinating where you can combine them. And there are times where Dr. Moosa will come to the OR and help us leave some breadcrumbs, I call it. He'll put some dye into the area, and then using the camera on the robot, we can flip a switch and look, and it will turn that area green where the dye was left. And so we know when we can find that needle in the haystack that we've successfully removed that area. And then it tells us, yep, it was cancer, or nope, it actually was a non-cancerous, benign thing. Perfect, we're done. Whereas if it's cancer, okay, let's finish the operation. We take our lymph nodes, we get the rest of the lobe, whatever we need to do for that patient. And that's all in the same event, same anesthetic event.
You both mentioned the multidisciplinary team at Our Lady of the Lake Cancer Institute being a really big part of the Incidental Lung Nodule Conference. And I'm curious if you can tell us a little bit about why this is so important in our treatment for patients and why this makes us unique too.
So multidisciplinary care really is the standard when it comes to cancer care around the country. So all national cancer centers have kind of a multidisciplinary approach. Care is just better when it's multidisciplinary, when you have multiple doctors weighing in with their own specific expertise on what the best way to approach something is. And the Lake has numerous multidisciplinary conferences. They have their own colorectal multidisciplinary conference, hepatobiliary conference, general tumor conference. But the conference that Dr. LeBlanc and I are most heavily involved in is our lung nodule or thoracic oncology multidisciplinary conference. And, we've built this program over the last several years, and we have several important pieces of it. We have the radiology presence, the interventional radiology presence with our Lake radiologists. There are so many disciples that we have pathology that started coming to our conferences, Dr. Nunez. So we are constantly growing our conference. And the whole premise is that when you bring a case and you discuss it at these conferences, you have so many different approaches or so many different perspectives from the different specialists. And they can all give us like kind of what they would look out for. And we have a collective approach to figuring out what the best plan moving forward for that patient is. So our conference is something we're very proud of. We have several visitors from surrounding cancer programs that have come to see how our conference is run, just because we've been fortunate to develop a program of this prominence. And so I really think it is one of the highlights and the core strengths of our thoracic oncology program in general. Dr. LeBlanc definitely goes to more multidisciplinary conferences as far as the other subspecialties than myself, because I know he's based heavily in the esophageal space. And so what do he should.
In fact, I was moderating this morning's tumor conference. because we have a rotation of a few of us physicians who decide to help out and kind of moderate the conferences. But I firmly stand by the multidisciplinary approach, setting us apart from a lot of other places. And it is the benchmark that if you want to be credentialed or have certification for a cancer institute or anything like that, that is one of the requirements that it asks, are these cases being presented? Because that's a check. The thing is, they want to know that you have brought these patients, even if it is a straightforward case where, yes, we're going to do this and then we're going to do surgery and whatever. You still want to have everyone else on board to weigh in who may think of things a little bit differently. So yeah, it may still require surgery, but hold on, why don't we get this taken care of first? Or did you think about getting that other scan? Well, actually, no, I didn't do that. And so that is for the best outcomes for the patient. Because from a surgical perspective, not all surgeries are the same. There is a difference of remove this area versus remove this area for a cancer reason, and that involves a little bit more than just going and cutting something out. And namely for us, it's going out and dissecting and removing all of these lymph nodes. Prior surgical operations, we would sample them, meaning just take a little piece of it. Well, now the recommendation is if you can, and you can do it safely, remove that entire lymph node so that you know that if it is negative, it is truly negative, and you didn't take a piece that there is no cancer in the lymph node, but you got the whole thing removed. And that is also part of the cancer, the oncologic, the cancer surgery guidelines that we have. And those are benchmarks that we strive to meet. And if we're not 100%, we're only 99%, but I'm pretty sure we're not 100% with all of those standards because they do review those yearly, and we certainly meet those standards. And that's what a patient wants to know and wants to hear, that they are, yes, we want to get you through the surgery safely, like I mentioned earlier, but we also want to do it in a surgical cancer way that we are giving you the best chance for survival. Well, what does that mean? You did the surgery's fine. Yes, but if I didn't remove all of those lymph nodes and I didn't find that positive lymph node because I didn't take it or I didn't look, well, now you were stage 1. Well, I didn't take that lymph node, that would have made you a stage 2, stage 3, so you did not get the appropriate after surgery care that you needed to give you the best chance of survival. And that's something we pride ourselves on for sure.
Yeah, absolutely. It's really clear that the team is so patient driven and what's best for the patient. And so I'm curious on what is your advice what advice do you have for patients and their families who are navigating a lung cancer diagnosis? Are there any examples that you can share with us of how our approach at the lake made a significant difference for them?
Well, I think, one thing that's fairly unanimous is it's a fairly anxiety-provoking and a stressful time in a person's life. I think I can see it on every patient that, obviously they're worried about what this biopsy could not show. So in that sense, it is a very, I consider it to be like a huge honor really for us to be involved in someone's care really at that time. I am a very spiritual person, and if I could, I guess, advise a patient or their family, I would encourage them to not allow every step of the way to weigh on their mind, and I would, once they come to our program, we are making every effort possible to try to expedite their care. We're trying to get things sorted as soon as possible, move them on to the next step of care as efficiently and as appropriately as possible. I would encourage them to lean on their spiritual side to really take some sense of mental relief. I think the mental stress of going through something like this cannot be understated. And so I always tell patients, look, these are things we can't control. And in times like this, I think it's very important to lean on spirituality. I think it's really helpful to help us in our own personal lives and in anyone's life to kind of get through difficult and stressful times.
Yeah, I agree with that. Certainly the spirituality and the religious component becomes a major factor, especially as Dr. Moosa was talking about, the things that they can't change. And again, it's easier for us on this side, but we have seen it directly and indirectly, and we can only offer our advice to say, look, you stressing is not going to change anything. In fact, it can make it worse. So whatever you need to help with that, family, friends, spiritual guidance or religious guidance, so priest, pastor, rabbi, whoever, that's up to them to utilize that. But I always encourage my patients to write their questions down or put it in their notes tab of their phone, since most everyone has a cell phone nowadays, and to make sure that they come and get all those questions answered, because invariably we'll walk in and they will forget the question that's been burning on their mind for a week. And that's completely expected. I mean, it's like going to the grocery store for stuff and you get 9 of the 10 things. Well, that 10 thing was the reason why you went to the grocery store and you forgot that. So write the list down and use the list. And so I do encourage Google search, but with a caveat that you cannot believe everything you read on the internet. And even talking with family and friends who may have gone through lung cancer, esophageal cancer, other cancer, their case is different than your case. And so that's another part that we try to get patients to understand, that yes, that may have happened to them, but I don't know their story and I don't know what stage they were. We can't answer all those things. This is you, this is where we know we are, and here's what we can do to help you.
Well, that's all the questions we had today. Is there anything that we missed that you want to share or would want to touch on before we wrap up?
No lung cancer screening podcast is complete unless we mention how terrible smoking is. And, I think if we could, the best thing, I tell patients all the time, is the best thing you can do for yourself from a health standpoint is to quit smoking. And so I think get that message out there is important. At this point, I feel like everyone knows that smoking's bad, but they need timely reminders. I think constant reminders to kind of re-emphasize and remind them how bad it is and how important it is to not let social things in your life, social stressors in your life, be a reason for you to, go back to smoking or make things worse by smoking, So I know patients often tell me that it's like it's a crutch during stressful times in their life. They go to smoking, and I think that that's difficult, but smoking is just making it worse. If not immediately down the road for that person, and so yeah, I think it's super important to emphasize how important it is to avoid smoking.
Yeah, that's a key point. Clearly we can't have this discussion without mentioning that. And it's fascinating. It truly is. I always tell my patients to keep at it. And when they let me know, I always ask what worked for you. Because they usually have one thing. It's, birth of kids, grandkids, whatever it was. And I always find that interesting. But some people, it's the first time they try to stop and they stop cold turkey. Some people, it's 101st time that they were successful to stop. But we do know that it does take multiple attempts. Like I was just reading that it takes usually on average about 6 times of people stopping and then before it actually sets with them. And it does help with having some other adjunct, whether that's behavioral therapy, going for a walk, doing something else with your hand so you're not putting a cigarette in it. Because people will trend down, and I do encourage that. So good, we're at a pack a day. That's great. You're not 3 packs a day anymore. That's phenomenal. Let's keep going. And by the time they're at 6, 7, 8 cigarettes a day, it's like, okay, that's muscle memory. That's habit. You can kick that part. And then it's getting them to do something else with their hands and their stress and things like that, going for a walk, doing anything else. And just to keep at it. I mean, that's it. Because even if we're not all the way to 0, decreasing is certainly of some benefit.
Thank y'all for talking through that. And thank you both for joining us today. We really appreciate your time and sharing your expertise with our with our audience.
Thank you for having us. It was a pleasure.
Thank you so much. We've enjoyed it.
Thank you so much for tuning in to our conversation. We'll have everything that Dr. LeBlanc and Dr. Moosa mentioned, along with other helpful resources and ways to connect with our lung cancer teams across Louisiana and Mississippi, linked below. Thanks for listening.